It's a pleasure to join you. This is a very important topic to me, and I think an underutilized treatment modality for some of our patients in need. So I'm excited to talk to you a little bit more about it, and thank you for coming. Let's see. Okay, so a few learning objectives today. So we are going to be talking about ECT, the indications, the use in psychotic disorders, also talking a little bit about what a course of ECT looks like. I understand some of you are clinicians, some of you are family members, some of you are patients themselves. And so a little bit more information about what to expect from a course of ECT, the different phases of treatment, the schedule, the side effects, that sort of thing. I'll tell you just a little bit about some of the potential mechanisms of action or ways that we think ECT helps patients with psychotic processes, and tell you a little bit about the literature or science behind some of these treatments. So why ECT? Why electroconvulsive therapy? Well, as many of you may know, 1% of the world's population has a diagnosis of schizophrenia. And unfortunately, about a third of these patients do not adequately respond to typical antipsychotics that are not clozaril or clozapine. So in this cohort of folks who are sometimes coined treatment-resistant schizophrenia, which is most often defined as a failure to respond or lack of success, I think is a more appropriate term, in terms of response or remission of symptoms to 2 or more adequate trials of antipsychotics. These patients have lower quality of life, lower cognitive and social functioning. They have a higher suicide risk, a higher risk of comorbid substance use disorders. And I think even more frustratingly for everyone is 40% of these patients do not even adequately respond to clozaril or clozapine, which we sometimes save for our most refractory patients, but even that isn't enough for some patients. So ECT for schizophrenia. Unfortunately, there's limited evidence for ECT as a monotherapy or as a sole sort of treatment, but really the best evidence is as an augmentation strategy to antipsychotics. The good news is that while the strongest data supports the use of ECT to augment clozaril or clozapine, there is also strong data to support its use to augment other antipsychotics. And while clozaril can be a very potent, powerful antipsychotic, not everyone can tolerate it. And so fortunately, this may be of high utility even for patients who are using it as an augmentation strategy for other antipsychotic regimens. One of the other things that I hope to emphasize and impart on you is that it's really important to continue these treatments beyond that first phase, which is what we call the acute phase, which I'll talk about in a few more slides. So even more important than in mood disorders, which is the indication for which we use ECT most commonly, it is so important to continue sort of tapering booster treatments beyond that first phase to keep the response, to maintain the response that we've initially achieved. And I think one of the things that's interesting is that the global trends of ECT use are so different depending on what part of the world you are, specifically for psychotic disorders. So in the US and in Europe, about 8 to 25% of patients who are receiving ECT are doing so for the treatment of psychosis. But in Asia and Africa, it is far more commonly used. Up to 80% of those receiving ECT actually are getting it for psychosis. So what is electroconvulsive therapy in a nutshell? So electroconvulsive therapy is the delivery of a controlled electrical stimulus while the patient is under general anesthesia, completely asleep, which induces a short, brief, generalized tonic-clonic seizure. These seizures are usually shorter than 2 minutes and are terminated if they last longer than that. The patient has no experience of the seizure because they're completely asleep. And you see here a picture of what we call different lead placements. So if you're someone undergoing ECT, or if you have a patient or a loved one who is receiving ECT, you may hear about this term called lead placements. Now, these are the 3 most common lead placements that we use. Most often for mood disorders, we use the middle, which is called right unilateral. Most often for psychotic disorders, we use bitemporal, also coined bilateral, which is both sides of the temples. The induction of a seizure is the same, but the tolerability and efficacy differs depending on the lead placement.
Staff assist to LV2.
Sorry about
Staff
that.
assist to LV2.
I'm in the hospital. Okay. So, indications for ECT in general, most often it's, as I mentioned, for mood disorders, so major depressive disorder and bipolar disorder. Interestingly, this is a little different than chronic psychosis, but major depressive disorder with psychotic features actually is a positive prognosticator for ECT. And what I mean by that is your likelihood of achieving remission with ECT is even higher if you have major depressive disorder with psychotic features than if you have a sort of non-psychotic major depression. In terms of bipolar disorder, interestingly enough, ECT is effective for all phases of bipolar disorder, not only depression, but also for refractory mania and mixed states. It can be helpful with severe suicidal ideation or intent, as we're here to talk about schizophrenia and schizoaffective disorder. Is sort of the gold standard treatment for catatonia. And so we'll touch a little bit about that, especially when those sort of features or symptoms are occurring within psychosis. Interestingly enough, also effective not only for the mood symptoms associated with Parkinson's disease, but can also be helpful with the motor symptoms as well. It can be helpful for people who have advanced dementia, for whom antipsychotics or other sort of behavioral modifying agents haven't been successful, for post-stroke depression, and interestingly for refractory status epilepticus, which is sort of seizures that don't terminate on their own, even despite medication management. One of the important things to know is that there are no absolute contraindications to ECT. Now, relative ones, yes, and we always do a risk-benefit assessment, based on the patient's medical comorbidities, sort of baseline risks, et cetera. But it is very rare that we say no. It's not safe to do ECT. We just need to optimize those medical comorbidities to make it as safe as possible. So, in terms of the indications within psychosis or chronic psychosis, as I mentioned before, treatment-resistant schizophrenia, as a reminder, that was someone who hasn't responded successfully to at least 2 adequate trials of antipsychotics that are not Clozaril. And then also Clozaril or clozapine resistant schizophrenia. Schizoaffective disorder tends to be have a more robust response because there's an affective component or a mood component. And then sort of based on acute clinical need or severity. So catatonic symptoms, affective symptoms, again, those mood symptoms, serious suicidal ideation or intent, violent behavior or agitation, failure to thrive, which can sort of go along with catatonia oftentimes, or refusal to eat or drink, a decline in sort of physical vitality or function, and sometimes an inability to tolerate antipsychotic medications, which can occur in a variety of settings. So the examples that I've provided here include things, medical complications or side effects related to antipsychotics, or certain sort of dangerous or high acuity states like neuroleptic malignant syndrome or who the first ECT patient was. The most common sort of consensus is that the first patient was treated by a neurologist by the name of Ugo Cerletti. And in 1938, there was a 38-year-old man with likely schizophrenia and an agitated or sort of hyperactive catatonic state, who, at least in the literature, they describe as having a complete resolution of his symptoms and significant improvements in functioning with ECT treatment. And even prior to the development of electroconvulsive therapy, seizure therapy, which was induced by a variety of mechanisms, has been demonstrated to be effective in affective disorders and mood disorders and in psychosis. So interestingly enough, in sort of ancient Greece, they were using electric eels in water. Someone would stand in a tub and they would try to induce seizures by getting stung by electric eels. And there was sort of, there's some lore around this being clinically helpful. And then there was also this interesting set of observations in patients who had concurrent or comorbid epilepsy, seizure disorders with mood disorders. And they would see that when these patients would have seizures, their mood disorders would temporarily get better. Before they used electricity or electrical stimuli to induce seizures, they used medications that would induce seizures, pharmacologic induction of seizures that does work. It's just not as well tolerated. As I mentioned before, ECT is commonly used in Asia and in African countries for psychosis. And before ECT was used commonly in mood disorders, it was actually originally used as a treatment for chronic psychosis or for psychotic disorders prior to the discovery of, chlorpromazine, thorazine, or other antipsychotics. So what does a typical ECT schedule look like? So I mentioned it a little, I touched on this a little bit before, but really there are three main phases of treatment, and you should be sort of familiar with what we mean by these different terms. So the first course of treatment, or the first stage of treatment, is what's called the acute series or the index course. In the United States, it's most often 3 times per week. In Europe, it's often twice a week. The outcomes are similar, but because it's a sort of cumulative treatment, you get a response more quickly if you're doing 3 times a week than twice a week. Once we've achieved response or ideally remission of symptoms, then we move on into a tapering course, which is called continuation therapy. So this is anywhere between that thrice weekly treatment and once a month. We don't really do an interval typically longer than once a month because there's not a lot of data to support that. And so we slowly taper. The speed with which we taper depends on the patient, how stable or sort of shaky they're feeling. And then once we get to monthly, you continue monthly booster treatments for 6 months. Once you meet that 6-month point, then we move on to maintenance. Not everybody does that, but a small cohort of folks feel like this is the only thing that's helped get them well and keep them well, and they continue on beyond the 6-month point. And on average, they continue treatments every 3 to 4 weeks for a longer period of time. Important to know is that ECT can be inpatient or outpatient, right? So the majority of people who start treatments with us start as an outpatient. I think one of the limiting reagents of ECT in the outpatient setting is because patients are receiving general anesthesia, they can't drive themselves home. So for many of our folks who don't have the psychosocial supports to have friends or family available to transport them 3 times a week for for an extended period of time, that can be a limiting reagent. But we're certainly working on trying to find sort of alternative modes of transportation for these patients. What are the common side effects of ECT? So ECT tends to be very well tolerated. I think in general, it tends to be more difficult to tolerate the anesthesia than the ECT itself, or I should say more of the side effects are most commonly related to the anesthesia. That can include nausea or vomiting, headache, muscle ache, and then there are some side effects related to the ECT itself. Without getting into too many details, ECT has different sort of hemodynamic phases, and it's sort of the middle most prominent phase is a sympathetic surge, which causes temporary sort of spikes in the heart rate and blood pressure. So when we're thinking about a risk stratification, right, the risks and benefits for that individual patient, we especially consider their cardiovascular health and anything that could put them at greater risk if there was an increase in intracranial pressure, which sort of is linked, is sort of the pressure within the skull, which can also go up temporarily with treatment. There is a risk of aspiration, which is essentially what it means is the stomach contents can come up the wrong way and go down the lungs and cause some irritation to the lung tissue, or at worst case, sort of a pneumonia. For that reason, people are what we call NPO, or without food or drink after midnight, to limit that risk. And then there's always these questions about cognitive side effects. I think one of the unfortunate sort of realities of ECT treatment is that it's a highly stigmatized treatment, and the way that it has been portrayed in the movies, in the media, on Google, if you read Dr. Google, is that you're going to lose all your memory. And I think the reality is with modern advances in the delivery of the treatment itself, the risk of cognitive side effects has been dramatically improved, has dramatically decreased. It's not zero, but with advances in things like the lead placement, before only doing bilateral, now sometimes doing the right unilateral, sparing the language centers on the left, but also advances in the morphology of the stimulus that we provide, things that are called like pulse width, which is a duration of pulses that we provide electrically. And also with the introduction of general anesthesia, the tolerability profile has dramatically improved. That being said, there are some cognitive side effects that can occur. Most commonly are a little bit of confusion immediately after treatment, which can happen for anyone who has a seizure of any kind and for anyone who gets general anesthesia. When people are doing the treatments 3 days a week in that acute phase, sometimes people aren't feeling quite as cognitively sharp, so maybe a little bit more fuzzy than they usually feel or are. And then there's when they talk about permanent memory loss, the thing that sounds so scary is that there can be this temporary sort of memory disruption or function of the hippocampus, which is part of the brain in the back, that transitions an observation to a long-term memory. That gets interrupted for a few hours. So for the few hours before and after treatment, people aren't actually forming new memories all the time. And so they may not ever recall those memories. They may not ever have those memories. It may be a loss of memory because they don't form them in the first place. And an analogy that I like to use is if you're not laying down the mortar and placing the brick in the wall, you're not going to see that brick in the wall later. Very rarely, people can experience what's called autobiographical memory loss, which is, again, when they're doing the treatments 3 days a week. Sometimes they have difficulty recalling very sort of short-term specific events like going to a movie with a friend 5 years ago, that sort of thing. That tends to get better with time as you spread the treatments out and as people recover and regain cognitive function. And again, as I mentioned, with these advances in lead placement, pulse width, treatment frequency, the tolerability profile has dramatically improved. So a little bit about the data behind the use of ECT for psychosis. So this is a famous study from the American Journal of Psychiatry by Georgios Petrides and colleagues, and they looked at patients who were receiving clozapine, that was the treatment as usual arm, versus clozapine plus bilateral ECT, which is the two sides of the head. Their mean clozapine dose was around 500 to 525 milligrams, so a good therapeutic dose of clozaril. And this cohort excluded sort of subtypes of symptoms that would be positive prognosticators for ECT, or things that might make ECT more effective or more likely to be successful. Things like affective disorders, mood disorders, schizoaffective patients, depression or active depressive symptoms, or catatonic symptoms. And despite that, 48.7% of the patients who were in the arm of clozaril plus bilateral ECT met a response, a definition of response at the end of 8 weeks, at least in regards to their positive symptoms. And importantly here, how they defined response was at least a 40% improvement on the BPRS and CGI, which are sort of measures of symptomatology and clinical improvement. Now, it's important to know that different studies define response in different ways. How do we define a cutoff of success? And one of the things I think it's important to know in terms of counseling your patients or your clients, or important to know as a patient or as a family member of a patient, is that this may not induce remission, complete absence of symptoms, but the response, the improvement of the symptoms can be meaningful and have meaningful improvements in quality of life and functioning. So this is another meta-analysis by Wang and colleagues that came out in 2018, a more recent study. And this was a meta-analysis of 18 randomized control trials, over 1,700 patients, again, for the treatment of clozapine-resistant schizophrenia, those who did not find success with a therapeutic dose of clozapine alone. And they had an even higher cutoff, a response definition of at least a 50% decrease in the presence and severity of those psychotic symptoms. And even with that sort of higher threshold, 53.6% of people at least met that criterion for response, with a number needed to treat of 3, which is quite low. It means it's a very highly effective treatment. And There was even a larger effect size at 6 weeks than there was at 1 to 2 weeks. And what I think that means, that my interpretation of that means, it's the acute phase for people with psychosis may need to be a little longer, a greater number of treatments than on average those for mood disorder. So it may be 6 upwards to 12 in that acute phase. But then it's even more important to continue with those tapering treatments in the continuation phase, because the gains continue even if you're tapering. So, as I mentioned before, fortunately, there's also good data to support the use of ECT for augmentation of non-clozapine antipsychotics. So this was a nice meta-analysis from 2016 that also looked at over 800 patients, 11 randomized control trials, and these patients were also quite treatment refractory. They had not had success with at least 3 different therapeutic doses of antipsychotics, and there was still a significantly greater number of people who responded with the combination of ECT and a therapeutic dose of their antipsychotic versus the antipsychotic alone. The effect size, again, similar to the other meta-analysis, reflected that not only was it important to do a little longer acute series, but that the effect size got greater as you moved the treatments out and you moved forward in the treatment course, again, emphasizing the importance of continuation phase treatment to help prevent relapse of symptoms and continue to accumulate gains. So, why do some people not respond to antipsychotics? I think that's one of the million-dollar questions we have in psychiatry. And there are a variety of theories. There's not just one explanation, but here are some that are postulated. And the reason why I think this is important is because then you ask, well, why does ECT work? And why is ECT helpful in this patient population? Again, I don't think there's one simple answer, but certainly we know that there are abnormalities not only in sort of brain circuitry, but also in the level of sort of brain inflammation, genetic predisposition. Brain volumes tend to be different, lower in certain parts of the brain, and that certain neurotransmitters tend to be abnormal in terms of their concentration. So we, through a variety of different sort of parts of the literature, we know that ECT causes an increase or leads to an increase in BDNF, which is sort of a pro-brain health protein. It causes the release of a variety of neurotransmitters quickly and sort of robustly. There are changes in EEG activity that seem to sort of normalize some abnormalities. There are changes in functional connectivity, how sort of airports in the brain connect and communicate with each other. There are increases in brain volume that tend to be abnormal or decreased in chronic psychosis. There look to be decreases in systemic inflammation that also may play a role in abnormal inflammatory states in the brain. And also, I think one of the things that's been very interesting to me as a clinician is that we see sometimes people tend to be more responsive to the same medications that they tried in the past after a course of ECT. And we postulate that this may be related to different sort of brain receptor or neurotransmitter receptor concentration and responsiveness. So again, I want to revisit this idea of what is response? How do we define success? And in schizophrenia and chronic psychosis, how we define response tends to be between 30 to 50% improvement in the symptoms based on a validated psychometric scale, most commonly the PANSS or the BPRS. Not unusual, which I think is true often in antipsychotic use as well, is that the positive symptoms of psychosis tend to be more responsive than the negative symptoms, unfortunately. Nevertheless, There are we also see some improvements in certain cognitive domains, both immediate and delayed verbal memory, executive functioning, decreases in suicidal ideation, decreases in 3 and 6 month hospital readmission rates, and reductions in annual treatment costs. So with that, I want to thank my colleagues. I'm one of the attendings on the interventional psychiatry service. We've got a fantastic group of sort of interdisciplinary clinicians, nurses, TMS technicians. I wanted to keep this somewhat short to really have a lot of time to answer any questions because I know you're coming from a variety of backgrounds and I'm sure have many. But also I would encourage you, if you ever want to refer a patient or even just ask some questions about whether a patient would be a potential candidate for these treatments, please don't hesitate to reach out to me at my Yale address. I think ECT, as someone who's an ECT practitioner, I think ECT is underutilized for a variety of reasons, and I think we're thinking about ECT a little too late. So even in early psychosis, if folks are struggling with the tolerability of antipsychotics, the efficacy of antipsychotics, I think those are conversations that should be had earlier in the treatment course and the sort of treatment algorithm. And we work collaboratively with the interdisciplinary outpatient teams to deliver this treatment modality. So just so you're aware, we're a consulting service. We don't take over the primary psychiatric care of the patients who are referred to us. So it is really essential that we get the input and have that sort of bi-directional collaboration with you guys, with the treatment teams, to give us feedback about the progress and the observations that you're making to help us guide treatment planning. Other things I would keep in mind, I think, again, this is unfortunately a highly stigmatized treatment, and I think it's a very misunderstood treatment. And I think that's one of the barriers to accessing this care. And so I would encourage your patients, to talk about this modality with your patients, but also to reach out to us and ask questions about candidacy, because I think the earlier that we introduce this for folks where we're saying, they're just not getting as well as we'd hope. Are we missing something? Is there an effective component? Are we not sort of getting them to the finish line like we'd like? This might be a really important sort of piece of the puzzle. So I give people some resources. There was a prominent surgeon by the name of Chet Newland, who's no longer alive, N-U-L-A-N-D, who did this really wonderful TED Talk. He was someone who had received ECT a number of times during his life, for what sounded to be more of a psychotic depression than a chronic psychosis, but nevertheless, he described it as life-saving, and he was a major sort of advocate and proponent for this treatment. So I think that's he's written about it. You can find the TED Talk on YouTube. Kitty Dukakis, of the sort of Dukakis political family and marriage of back in the 70s, has also been a strong, outspoken advocate for ECT treatments, and has written a book called Shock, which I think is somewhat unfortunately titled because we don't really coin it as or to use the term electroshock therapy. I think it's more appropriate to use electroconvulsive therapy, but nevertheless, she talks about her own personal experiences with ECT and how it was life-saving for her. I also recommend people going to NAMI, the NAMI website, because I think that's a good resource, as well as the ISEN website, ISEN, which is the International Society of Electroconvulsive Therapy and Neurostimulation. And so I like to provide resources, and I like to sort of introduce it in stages and phases, right? So there, you could phrase it like, there are alternative treatments that can help your antipsychotics work better. Sort of acknowledging that it's a highly stigmatized treatment, but it's actually very well tolerated and safe. But I think part of the conversation is also it is one that we have as the consulting psychiatrist when we see those patients in consultation. So I think a very important part of that discussion when we're seeing patients in consultation, when you refer patients to us, is to answer their questions, to address any misgivings, concerns, questions that they have, because most people come in saying, I'm a little scared of ECT. And it's our job to ensure that all of those questions and concerns are answered so they feel more confident in that decision. Yeah, that's a great question. I think it depends on the patient. Um, so I would do at least 6 to 12 treatments to call it a fair acute series. And we utilize a validated psychometric scale through the treatment course. So we'll do the PANS or the BPRS at intervals through the acute series, along with incorporating clinical impressions from the primary team, hearing from family members, hearing from the patient to make a best assessment about clinical progress. And so if there has been no progress whatsoever, let's say by 12 to 15 treatments, we usually say this is probably not the right thing to do. But if there's very slow incremental progress, then we usually continue beyond that because, as the data reveals, and also in my own clinical experience, I have found that some patients who are receiving ECT for psychosis have a slower response than those with affective disorders. Yeah, so I think what I would say is more of our patients who are in maintenance, which is that third phase, right? More of them have, let's say, chronic psychosis or schizoaffective disorder, where it doesn't tend to be an episodic illness, but rather more of a chronic illness that ebbs and flows in its severity. Those people more often tend to choose to pursue maintenance treatment. Most people with affective disorders who have been in remission for 6 months, let's say, if it's been their first or maybe second episode of depression, choose to stop and sort of watchfully wait, watch and wait, and see, over a period of months while maintaining other sort of holistic uh, treatment, parts of their holistic treatment plan, medication, psychotherapy, et cetera, whether they can remain in remission. The folks with affective disorders who tend to stay in maintenance are those who have relapsed when they stop ECT. Um, now, when would I stop ECT? I mean, I think the most important thing is what the patient wants. And with few exceptions, for chronic psychosis, it is the patient consenting to treatment. And so a lot of the time it's at the behest of the patient saying, I feel well and I'd like to stop. Um, but, I think in terms of long-term ECT safety, the evidence overwhelmingly suggests that this is a safe treatment, even with ongoing maintenance. They have histopathologic studies, they have imaging studies that suggest that this is a pro-brain health treatment. And so we don't stop because of concerns that people have been doing it too long. We focus on patient functioning and control of symptoms, patient autonomy and choice, and preference, and optimizing tolerability. So really, my last point would be, if people are really having a tough time tolerating the treatments, obviously we do everything we can to optimize that and minimize side effects. But if it's really become intolerable for them, that might be another reason we taper off. While I lament acknowledging that insurance coverage plays a role in sort of my clinical decision making, TMS is not currently FDA approved for psychosis. So, as many of you may remember, Ralph Hoffman was here about a decade ago before he passed, unfortunately, and was doing really groundbreaking work on TMS neuromodulation for auditory hallucinations. There is some data to support the use of TMS for those patients, but because it is not FDA approved, it is not covered by insurance. So That is something that plays a role. Certainly, TMS as a modality is highly safe and can be effective, but it's also it's a big commitment. It's typically 5 days a week for a number of weeks. So for people who have transportation limitations, that can also play a role in the decision-making process. Um, I would say TMS is still experimental for the use for the treatment of psychosis. So certainly it's something we'd be willing to consider. It's just tough to get patients access to that modality because it's expensive and it's not covered by insurance. There's always this sort of balance to be found between efficacy and tolerability. And I think there's no right or wrong decision. It's all relative based on the clinical situation, the acuity, the severity of the symptoms, and the speed with which you need to obtain a response. So bilateral, bitemporal, which is interchangeable, is going to get you well the most quickly. It does have the highest incidence of cognitive side effects. Most of them tend to be temporary, but again, as I mentioned, those few hours before and after treatment tend to not really come back sometimes because they're not formed in the first place. Now, certainly that's as a cohort, right? And there are patients, unfortunately, who do describe at times that they have more difficulty with cognitive side effects more chronically. It's very, very rare. And I think what makes this very difficult to study is that most people who are coming to us for ECT are sick enough that they're not cognitively functioning at full speed at baseline, right? So someone with profound depression, someone with severe psychosis, those patients as a cohort also don't often sort of score as highly or as functionally as their age-matched healthy peers, right? So it becomes very difficult to parse apart, was this the ECT? Was this their underlying illness that was impairing cognitive functioning and memory consolidation? So I think we have to take it on a case-by-case basis and certainly do everything we can to optimize tolerability while also optimizing efficacy. Yeah. So I would say that one of the limitations to accessibility is transportation, right? And it's an unfortunate reality that, as I mentioned before, because people are getting general anesthesia, excuse me, they may not drive themselves home. And that's really a limiting factor for many of our patients, especially in this cohort. Um, and it's a little different than a once every 3-year colonoscopy, right? This is a major commitment, not only by the patient but also by their family or friends, to be able to provide them transportation for a month, let's say 3 times a week, right? So that tends to be a barrier to accessibility or to access. I think a barrier to access is a lack of referrals, also a lack of consideration of this treatment for this population for whom it can be highly beneficial. I don't think it's on the sort of wavelength for some people because it's so often linked with mood disorders, right? But I think it's underutilized that way, and perhaps some of the people who would be good candidates are not being referred or considered in the first place. In terms of the literal sort of locations for ECT, the two main ones are us and the IOL up in Hartford. I do think that there are a couple of other small clinics that may be popping up in the next few years, but those are really the two main sites of Connecticut, which again is a limit in itself because it's a long commute for people who live in certain parts of the state. I actually can get you the link, if I can pull it up here, to refer, and I can put that in the chat. Um, and if you ever want to refer a patient, we do require that the um, primary psychiatric provider does the referral. It can't be patient initiated, but we're always happy to field questions, concerns, if you don't want to do a formal referral quite yet.